When babies are born with complications, they usually wind up in neonatal or paediatric intensive care. Mothers and babies are routinely separated for weeks or even months. Babies in care can still get the benefits of their mother's breast milk. But sometimes things can go wrong.
Yeah, so one of the issues in the pediatric universe is that moms will pump express breast milk and then it's stored in a milk bank and then it needs to be delivered to the appropriate baby. And one of the errors that sometimes occurs is mom's milk goes to a different baby.
This is Jordana Goldman.
I am a pediatric intensive care physician, and I specifically have a role in quality and safety for critical care and for the Heart Center, and then was working kind of also on the hospital-wide level to advance safety science within the institution.
When errors, like this mix-up with the breast milk, continually crop up in healthcare, institutions typically see this as a problem with their operational systems. Most often, they turn to health administrators and systems experts to fix it. But frequently, their recommendations simply increase the day-to-day burden on healthcare workers, while doing little to prevent these errors from happening again.
The models that we've been working with, which are just more regulations, more box checking, more confinements, really haven't made significant progress, and if anything, sometimes just impedes people's natural ability to do their work and to be able to make the adjustments that are needed to get that good outcome or what we're driving towards. And so as we're learning about this and we're seeing this event unfold, and it seems so simple, but it just keeps happening, it made us think, like, could we look at this differently? Is there more here?
Jordana wanted to take a different approach, one that harnesses the expertise of those actually doing the work.
A group of us have been studying and learning about improving adaptability, introducing the concept of resilience. So the setting that this is occurring in is a large pediatric academic facility with multiple towers and multiple NICU locations and separate towers. And so while babies are in-house, if they're not able to breastfeed, the moms will go to these specific sites, or they can bring in their milk from home and deliver it to the milk bank. And so it's a whole process to label the milk, to store the milk. It gets processed and thawed, delivered to the patient's bedside, and then the nurse will do some checks and then ultimately administer it to the patient. We had two milk banks, and one functioned very fluidly and one was starting to have some real challenges and had kind of a couple episodes where wrong milk had been delivered or administered to a patient. The topic became, how do we address wrong milk delivery? And that was kind of the nidus for the learning team.
Learning teams is an improvement concept that's about bringing people together and learning from the people who are on the front line every day. It's about learning from those who know what is working well and what makes their job harder or less safe.
The scenarios where we need to store mother's milk and give it back to the babies are situations where the baby is hospitalized for days or weeks or even months. And so it's just impossible for the mom to be there 24/7.
So you might be thinking, is milk going to the wrong baby really such a big deal? Well, it's an issue for a few reasons. One of the biggest problems is that the mother can experience emotional trauma. She's trusting the hospital to care for her new baby, who's already got all these problems. They can't even get the milk right? What else will they get wrong? And besides all this,
Mom worked pretty hard to get that milk and it should go to its right location.
So at first, to address this issue of wrong milk delivery, the hospital brought in their Six Sigma team to try and solve the problem with process flow and lean thinking. But they didn't really get to the heart of the problem.
how much you interact with the people who are doing the frontline work and in what ways you're interacting with them can really significantly affect the output that you get from that methodology. And so if you're working a lot on spaghetti diagrams and things like that, you could potentially really improve the efficiency. But there might be a really interesting reason why they're taking this circuitous path. And if you're not asking, then you may miss a really crucial point.
A learning team looks to explore the gap between work as imagined and how work is actually done. And this can be where crucial pieces of information slip through. The problem with work as imagined is that it's constructed and designed in a perfect world. By looking through the lens of how work is actually done, we gain insight into the conditions and constraints that frontline workers encounter. We also learn about the tactics that they use to adapt their approaches on a case-by-case basis.
We started with choosing who would be the facilitators for the group. We had two of our patient safety specialists who are nursing trained be the initial leaders, and then I joined on kind of as a content expert.
In a learning team, it's essential to get people who regularly do the task you're analysing. But the team has to be a mix of people with different degrees of experience. The perspective of long-term employees versus short-term employees can really be quite varied. No supervisors or leaders. They are the recipients of the learning team, not the participants.
The value of having non-content experts in the field asking the questions, because the curiosity is just more native, and because we just ask very simple questions that don't make sense to us, that make sense because you're so used to being there. Like these assumptions that you've lived with, they don't exist with the strangers who are entering your environment.
The success of a learning team depends on curiosity and openness. It's important to create an environment where participants feel that they can share how the work is actually done.
Being curious is, I think, one of the more helpful pieces to the facilitating a learning team, because if you're not in the everyday of it, things that people have just taken for granted that are challenging, they may have forgotten that they were challenging, or they don't have to be that way. And so when a stranger comes and says, well, but why are you always only turning left? And they're like, oh yeah, my right blinker's broken. You're like, oh, okay, great. Do you want to fix it? So we discovered that setting up a 3-hour meeting in a healthcare environment wasn't a thing. The learning team, traditionally you have 3 or 4 hours, and then you have some soak time, and then you meet again very quickly. But the meeting cadence at the organization tends to be every monthly. So we'll see you again next month and we'll talk about this again. And that just doesn't work for the flow. So what we ended up doing, knowing that we only had an hour, was we decided to just start with, tell me about your everyday. And ultimately, once they started talking, they filled up that hour very quickly with just what the day was like, good, bad, and different, just the flow. They never get lunch.
Once this process began, a lot of powerful insights started to emerge. These insights were not part of the administrator's recommendations, and in fact really ran against them, but were nonetheless grounded in the common sense of those at the coalface. In particular, the team identified 2 key problems in the process. The first one had to do with adding calories to breast milk.
So one of the biggest frustrations to the team was that the way that the orders were written, the kilocalories, the kcals. So standard breast milk is 20 kcals. Then if babies need to grow more, or we have to volume restrict them, we do more kcals, like 22, 24, 26. And so the order has the option to add kcals to it. And then at the end, there was a second place to put how many kcals they wanted the milk to be. This is one of the first things that came out, and they went off on it. I mean, they just talked about it for a good 10 minutes. And so basically what happens is it's there twice and the physician will put it in. And so it has to match. If you want 26 kcals up here, the bottom of the order also has to say 26 kcals. And it goes off, into the magic computer land and spits out into the milk bank. And if there's a discrepancy, they can't fill that request. And so then what they do is they have to call for clarification. And when they call for clarification, Sometimes people just aren't very nice when they receive that call, and it's just a big waste of time. Well, I put 26. Why are you calling me? Well, the bottom says 24. Can you change it? Yeah, I'll change it. Click. And then it doesn't get changed. And then the milk doesn't get filled because it hasn't been changed. And then the milk is late. And then people are upset and the baby isn't getting their milk. And it's like a whole thing. And everybody's upset.
So this was an administrative process with a number of groups of people in it. And those groups of people are looking at it in their own silos. One group is really invested in this process. They want to get the right milk to the right patients. But for the other, it's really just another transaction.
One of the solutions I offered to them, for example, was, well, if we took those two options out of that milk bank order that are discrepant sometimes and cause a lot of challenge, would that be helpful? Is that necessary? Is it helpful in any way to have those two pieces? And they were like, oh yeah, please get rid of it. Done. It was like fixed the next day. So that felt good. That was a really, really easy win. And those don't happen that often. So I was very thankful for it.
And the issue of wrong milk delivery? The learning team developed a simple and ingenious way to lower the chance of a mother's milk going to the wrong baby. An elegant solution that went beyond the administrative status quo.
They weren't quite exactly using what I would say is true two-step verification or two true patient identifiers. So one of the patient identifiers that we classically use is last name, but last names aren't very unique sometimes, and especially in certain populations. My last name's Goldman, so there's not a lot of us in Texas. Using that as a patient identifier is kind of an opportunity for loss in your checks and balances, because there's going to be a bunch of Goldman babies potentially, and it no longer is significant. So what they had before was somebody's full last name and then their full medical record number. There were a lot of errors, I think, because people were using the full last names and just putting it in the bins.
The solution involved taking the first 3 letters of the surname and combining it with the last digits of the MRN.
And so when they took away the full last name, so you couldn't just pick Goldman, and had to look for something else in order for it to be significant to go into a different bucket or a specific bucket that lasts for the MRN, that had actually decreased their work burden and increased the likelihood that it would end up in the right bin.
This solution taps into something cultural. Looking at surnames, often the same surnames, day in, day out, creates a risk of a mix-up. So rather than full surname, full MRN, this solution involves taking less information, but combining it into something that forces us to take a second look. The learning team's solution really forces hospital staff to passively perform a 2-factor authentication every time they look at a label.
When the administrators come in and the engineers come in and they look at it, they think this is crazy because they don't think about the human factors piece of it.
It's a solution that didn't come from the experts. It came from giving a voice and listening to those carrying out the work.